Thank you for joining us. We're so glad to have everyone with us today for this third part of our telehealth series, a third of 6. So today we'll be talking about telebehavioral health and the role-based long-term care facilities. Today's webinar is being recorded by the fabulous Caleb Lewinsky, and so he will be sending, he is on the call today, and he will be sending the recording and the slides to the participants at the conclusion of the 6-week series. So I am Kim Mayo, and I am a program specialist with the DRCHSD program, which is providing the webinar today. The DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. So today, you can see today's webinar, and then for the next 3 weeks after this week, we will have more great topics coming up. So post-COVID patient transitions on the 11th, industry-based technology programs on March 18th, and then to conclude the series, we'll be talking about analytics to measure your telehealth outcomes. So again, welcome everyone to today's third telehealth webinar. And before we get started, many of you are already doing that, but if you can find that chat box and type in your name, your organization, your title, that really just does help us out to know who's here and get a good feel of our audience. And we will be using that chat box for questions if there's discussion, as there is discussion, and you can either unmute your line and speak or use that chat box. We do ask, if you are not speaking, if you could keep yourself muted. That really helps to cut down on any feedback and background noise that happens. Now, I'd love to introduce our speakers today. We have probably familiar with most of them. We have Donna McHale. She has over 30 years experience in the healthcare industry and is a leader in Huron's healthcare technology services. And then we have Jessica Duke, who has over 16 years of experience in the healthcare industry and is a registered nurse with extensive experience in patient care management, process improvement, and telehealth. And then our guest speaker today, Dr. Catherine Demiu, will be joining us just a little bit later. And to start things off, I'll turn things over to Jess, I believe.
I think I'm going to start.
Okay, then Donna will take it away.
Hi, everybody, and welcome back. We're so happy to have you back. So just to run through the agenda quickly, I'll start out talking to you a little bit about some of the behavioral health trends that we're seeing. And then Jess will pick up and talk to us about what's going on with this long-term care population, some of the return on investments that we've been seeing, and some of the gaps and barriers in spending. And then a little bit about some of these long-term care programs that we're seeing. And then Dr. Kathy comes on, and she's going to have a very powerful session about what she's seeing in virtual behavioral health. I've heard her talk about this before, and it's very powerful, so I think you'll enjoy that. And then we'll talk, have a little bit of a panel discussion. You know, we like to do that, and then I'll give you a couple of takeaways. So next, please. So I think I covered this already. You know, we're going to learn a little bit about what the trends are and what's going on with the patient population in these long-term care facilities, and then help you understand what the different gaps and barriers in spending are related to what we're seeing in telebehavioral health. And then give you some ideas as to the benefits that patients, providers, and organizations will see from these telebehavioral health programs, as well as the impact. And of course, we'd love for you to network and make new connections and have some fun. So then next, please. And Kim talked about this already. We're going to have a couple of questions during the session. And so all you need to do is, as she said, raise your hand or use the chat box, and we'll be monitoring that. So let's talk a little bit about what's going on. HFMA did an interesting study where they brought out some of the trends that are going on for behavioral health within long-term care facilities. So a couple of interesting statistics here for you. 1.4 million people right now reside in long-term care facilities. And what's interesting is look at that increase by 2050. So in 30 years, an increase of 80%. That's huge. So this is going to be a growing and expanding marketplace. Another interesting stat is around the senior population, and that 50% have Alzheimer's or some other form of dementia, and that 30% of the long-term care facilities are located in rural areas, which I think you're all very familiar with, and they have limited access to the behavioral health services that they need. And a very similar statistic is around the fact that 65% of people who are living in those types of areas don't have access to a psychiatrist. And that 1 in 3 of these facilities are having a hard time to adequately provide for the behavioral health services that their patients need. But what to keep in mind is by improving access to the behavioral health services, it reduces the healthcare costs and it really improves what's going on within the long-term care facility between nurse and patient interactions and the quality of the patient's life. So some pretty interesting statistics here. So I'm going to turn it over to Jess now so she can walk us through a little bit about the population for the behavioral health folks. Jess?
Absolutely. Can you go to next slide, please, Caleb? So I think it's important to kind of understand the patient population being served in the LTCs. Certainly dementia is a big portion of the patients that are in the LTC. It affects about 50 to 70% of the residents. When I first read this, I was kind of taken back by that. In one study I read, it said that 3/4 have difficulty making decisions, and then 2/3 of them have difficulty with memory loss or even cognitive challenges. And then there's this other portion of it that have the pragmatic behaviors. I remember very well taking care of those patients. They can be combative, they can have be physical or even verbal abusive. I remember them being the spitters, the biters, very difficult to care for. So we know that burden on the providers that are within the LTCs. They can be acting out, they can be resisting care. Those are also your wanderers, which is a huge safety concern. They're also limited in communication. So the other component of this is depression. One study I read talked a lot about how there's more depression for these residents than if they had lived within their community, because they don't have the network and the lifestyle that they're used to. They're pulled out of their community. And then the other component of this is the disabilities. So the most common reason that the older adults become a resident is because they no longer can do their ADLs or activities of daily living. They typically have 80% of the residents need help with at least 3 of their ADLs. So that kind of gives us a glimpse of the patient population that is living within these long-term care facilities. So let's go to the next slide. So when we start to think about the return on investment for behavioral health, there is some correlation to an ROI. When you increase the number of behavioral health visits via telehealth, there is an increase of Medicare revenue associated. There is an indirect revenue with avoided hospital services and avoided emergency department visits. And then there is the expense of putting the telehealth equipment, that upfront expense. It can be saved because of the non-hospital visits that you're not having to incur at the time. So there is some upside to it. We'll go next slide, Caleb. All right, now we do need to talk a little bit about some gaps and barriers, and then also the spending associated with the population. So 1/3 of the care facilities, they lack the behavioral health services. And then almost half these facilities are lacking behavioral health education. And this is the education for the staff that are within the LTCs. And then over 30% don't have adequate care coordination. So they're not able to deliver or coordinate the services back to these residents within the communities or in the LTCs. And then 26% don't have adequate infrastructure to transport or transfer the patients to the facilities that they need to go to. So that's where telehealth really comes into play, because then it can help facilitate getting the services to the patient. And then it doesn't if they don't have the infrastructure to transfer the patient, then with telehealth, you can deliver the services within the LTC. And then when you think about the spending that's happening, 36% of the total national health expenditure each year is in the LTCs for these type of patients. $460 billion is spent on non-medical, which would be behavioral health services, just yearly in the LTCs. Because this is a huge population. If you think about your baby boomers, that's what's funneling in here. So we'll go next slide. And this is our first question. So this is what we're going to feed into. You could do it in the chat, but I would actually prefer it. Let's come off mute and let's engage in some conversation here. I'm curious, does your community need telebehavioral health for your LTCs? I know a couple sites that we've worked with are going this direction, and I'm kind of curious on where you're at with this. So does anybody want to come off mute and start this conversation?
Hey, Jessica, this is Pam at Henry County.
Hey.
We have actually just had a conversation on Tuesday kind of about this very topic with our long-term care facility and their needs for that. And we actually have a psychiatric floor in our facility and nurse practitioners and a psychiatrist that, run that unit. And so we have started looking at that and talking about that a little bit more, I think, than we have in the past. Because we probably are a little bit better able now to provide the service than we were previously.
Pam, why do you think it's happening more so now? Do you think COVID is driving that?
I think so. That's part of it. Yes. And, the facility's still not open.
Okay.
And yeah, I think, and that, I don't really know if the numbers have really increased, anymore as far as the patient population in the facility, as far as, if they're experiencing more depression and more of those type symptoms, that they need maybe that type of service right now, since they haven't had people to be able to come and their loved ones and things to be able to come into the facility now in over a year. Yeah, but I think that's some of it for sure.
Do you
just not allowing not allowing visitors in the facility, and even some of the providers don't want to go, into the facility. They had rather, do it some other format if they can without having to go in.
Absolutely. Do you currently get the patients into your emergency room?
We do.
Okay. So the thought is that you would you supply telehealth equipment to them?
Yes.
Okay. And then, so then that's how you would communicate into the LTC.
Yes.
Got it. Any obstacles that you think you're going to have creating that relationship?
I don't think so. I think our administrator for the facility is on, Sandra Ray, but she says she's having trouble trying to unmute, so she's probably not able to talk. But no, I mean, I don't think so. She may, have other thoughts on that, but I don't think it would be, because I think they're pretty open to doing that, and it's best, if it's best for the patients, that's what they're about, is the quality and providing good quality of service. So I don't think we'll have an issue with that.
So
Yeah.
Sandra Ray, if you have any concerns, you can put them in the chat box and we can read them for you. Or if anybody else, while Sandra is typing, wants to come off mute and talk about their journey with the LTCs, because I think this is good dialogue to kind of see where you're at with this, where your progression is, because I think this is a good knowledge share moment. Is anybody from Sparta able to share? I know Sparta was working towards this as well. Okay, so Sandra says out-of-town facilities are wanting us to have telehealth services. It would be very beneficial to our residents and very helpful financially. Sandra, are you looking to have this for telebehavioral health, but are you talking about other services outside of telebehavioral health when you say out-of-town facilities? Pam, do you know the answer?
Yes, the answer to that would be yes. So like, if they have some provider in Nashville or something like that,
Awesome.
that they could do telehealth visits with those providers as well.
So maybe the basis to start with would be telebehavioral health and then expand out from there.
Or yes, it could be that or vice versa, either way, you know, but yeah. Mhm.
That sounds awesome. That's very exciting. I know somebody else has to be thinking about this. Judy, from St. John, have you guys ventured into this at all?
No, I don't think that has been a discussion yet that I'm aware of. I mean, we're struggling with even getting psychiatric physician to be part of our organization. So we're working on trying to do a telehealth site, but I don't know that there's been any discussion about doing it with long-term care yet.
Trying to think who else. Amy from Marshall Browning, have you guys had that conversation at all?
To the
Putting
best
you
of
on
my
the spot.
knowledge, we haven't really. We've got a fairly decent relationship with our long-term care facilities here in the community, and you know, our providers are the primary for most of the residents in the 2 facilities here in town. Like a lot of hospitals, I think that, you know, we are really excited about the thought of getting telepsych just for our ER. And to, you know, the idea of being able to expand that to the long-term care facilities here in town, I think would be awesome, because we have in probably the last couple of years, the facilities have accepted a couple of patients who have been very challenging behaviorally, and had pre-existing mental health issues, and to be able to deliver services to them, you know, where the patient is at, rather than because I think sometimes, you know, taking patients who have behavioral challenges out to appointments presents a whole other set of issues, especially if your staff is not necessarily got training focused on how to handle those behavioral issues. So I think that once we're more well established as far as our telehealth goes, that's an area that we're definitely probably, you know, gonna look at exploring.
Absolutely. I think that's a great point. It's kind of in that whole, if you think about the care continuum, it's like another phase to the care continuum. Well, thank you all for giving your insight to it and where you're at in that journey. We'll go ahead and move on to the next slide, Caleb. So if we think about it, you know, in that care continuum, like we've been talking with the last 3 presentations, and the rule-based long-term care program, obviously the benefits to the patient is improved access to care and the patient outcomes. You know, the ideal piece of it is that you're going to reduce the stress, just like Amy just said, reduce the stress and the confusion due to the environment changes. You're not taking them out of the facility. They're not going to be maybe as combative in that sense. And the risk of reducing the risk of injury related to the transfer. The benefit to the LTC is you're improving the quality of life and the patient outcomes, you're decreasing the cost of care and potentially decreasing the transfer rate to the ED. The hospital benefit is you're increasing the market share, you're, you know, and decreasing unnecessary ED admissions and readmission rates. The technology enablement is the same that we've been talking about in the last webinars with, you know, the 2-way audio video, or even the video, verbal and audio synchronous visits. But these barriers kind of remain the same. We have to make sure that there's access to that technology. Even the digital literacy, and the digital literacy may even be with the staff at the LTC. We have to make sure we educate on the other end. So we'll go next slide, Caleb. So at this point, I'm going to turn it over to Kim.
Awesome. We are very honored to have Dr. Catherine Demiu here with us. She is from the Midwest market, medical executive for Cigna Healthcare, and she provides medical leadership for the Midwest market, which includes Illinois, Indiana, Wisconsin, Michigan, and Minnesota. She is responsible for supporting physician and hospital collaboration, new business development, client relations, as well as the Midwest market's strategy and financial planning. So please, Dr. Demiu, take it away.
Thank you so much. And it's a pleasure to be with you today to talk about this very important topic. As Kim said, I oversee value-based care for the Midwest. I also still work as a hospitalist, and in prior roles, I oversaw care management for a large medical center in Chicago, as well as worked in long-term acute care facilities. So I understand the challenges of providing care without optimal access to consultants, and certainly want to share with you the trends that we're seeing with virtual care, and really understanding the increase in stress and loneliness from COVID-19 and the focus and impact that this has had on our overall population. So I know it's important to this group and how this has impacted rural communities especially, and so I'll also go through our thoughts on where we need to go post-COVID, because obviously COVID gave us a silver lining of virtual care where we're able to transition really quickly, and so we want to make certain that we utilize that sea change that we had. So going to our next slide, I just want to briefly touch on some general statistics about behavioral health in general, and then I'll focus in a little bit more on the impact to the rural community. So prior to COVID, 1 in 5 individuals struggled with mental health. And this was pre-COVID. This is probably much higher, and we're still waiting for kind of those final numbers to come in. But overall, 7% of folks living with depression, 19% with an anxiety disorder. And then, we have really been impacted by substance use disorder. We saw this really come to play in the pandemic, where we did see a rise in substance use disorder and overdose. So really a huge impact to society on behavioral health. And then, understanding that this is a little more profound in the population that you care for in long-term care. So understanding that the impact of Alzheimer's, isolation, COVID, folks not being able to come into your facilities to visit their loved ones as readily as they used to be. This has all impacted folks tremendously over the last year almost. So moving on to the next slide. And as I mentioned, this was pre-pandemic, and Cigna actually has been looking at the impact of loneliness on overall health outcomes and depression and anxiety. So we've done 2 studies looking at loneliness, which we think is a big impact on overall mental health. And these 2 large national studies we've done use the UCLA Loneliness Scale, which is a research validated tool. And looking at adults, first in 2018, we found that 54% of adults identified themselves as being lonely, which is remarkable. And then we had a follow-up study last winter, and again, this is prior to the pandemic, and that increased to 61%. So you can imagine what that has done in the long term to our population. One of the surprising things was that young adults were most lonely of all. But again, this looked at a population that did have access to internet, and so it may have underrepresented the impact to long-term care, rural communities, because folks just didn't have the ability to participate in these types of studies. So that lesson may kind of inform our overall strategy in looking at loneliness and its impact. So when we look at the impacts of loneliness across America, men were more lonely, younger people, as I mentioned, were more lonely, but also the impacts of urban and rural communities was, I think, profound, where folks, needed to improve their connections with others. We did see that social media users who were heavy social media users were had a higher incidence of loneliness. However, if you look at folks who use social media to interact with other people, so I think we're all on Zoom, we're all more virtual, it's a different world out there. If you're using social media to connect with people, that helps to kind of temper the impact of loneliness. However, if you're using social media just to kind of look at things, that that makes folks feel more lonely. And then, just want to, briefly touch on the impact to rural communities. Rural areas have a unique set of circumstances that can exacerbate that social isolation, especially of older residents, leading to poorer health, loss of independence, lower quality of life. And these factors can range from, lower expenditures on social care and greater reliance on car ownership. And obviously, if you have folks who are in long-term care, it may not be those folks who are impacted by that, but it may be the folks that are coming to visit them. They may not have access to cars. They may not be able to come in and visit. And then again, the impact of COVID was profound, and it really has changed the way we look at things for these populations. Going on to the next slide. Let's see, sorry, I think I'm missing one slide. So anyway, I want to talk about just the different waves that we've seen in terms of the impact of COVID-19, and then I'll go on to our utilization data that we've seen in terms of our outpatient telehealth claimants. So, I think folks understood that we experienced with lockdown, impact to healthcare, folks not accessing care. We've kind of come out of that now, but there was a second wave of an impact that really profoundly affected mental health, because we saw an increase in depression, anxiety, substance use disorder, overdose, and suicide. And we also saw a huge increase in alcohol use disorder and the impact that brought to that population, both medically and mentally, in terms of total outcomes. So those negative impacts really made us understand what we needed to do in order to pivot, both as an insurer, but also as a medical community, because I still practice, and we needed to have the ability to reach out to folks in a safe way and in a way that we could connect with individuals to understand what they needed, make sure they were safe from COVID, make sure they were able to get their care, and to do it from the comfort of their own house was a great way of being able to connect with people, especially with mental health. I think you folks understand that mental health disorders have a lot of stigma associated with them, and being able to access that care virtually is really important. And then for folks who are kind of not able to get in to see their physician or see their therapist, being that lifeline of virtual care is incredibly important, and it really allows us to connect with people in an easier way. And also, when you think about contracting for those providers, it doesn't matter where you are and where your provider is anymore. You can access someone who's in California, who's in Texas. It doesn't matter where folks live anymore, because you don't have to travel to get there. You can access that from a tablet if you're able to utilize that. And the other thing that we were able to do was to actually promote the concept of an e-consult. And this is a former practicing long-term acute care physician. It's very nice to be able to consult someone, go out electronically, have them be able to bill for that service, have me be able to bill for that service, and connect with another provider, even if they're not able to get to that facility, with a clinical question. So I need to address someone with some behavioral disorders. I need to figure out what the best medication is to start them on, and I can do that virtually. And that's amazing progress that we've made since the pandemic. So just wanted to bring that up. In addition to that, there were also a lot of changes that were made in the regulatory space. So easier for people to access virtual care because different states, CMS were able to allow providers to practice across state lines. Many states accelerated the licensing process to help providers get temporary licenses and provide that virtual care. quickly. So we've made great leaps because of those changes, and it's really allowed us to really expand our virtual care. So this data allows us to look at the utilization that we saw at Cigna. So you see that giant spike up in March. We had over 4,000 providers sign up for telehealth in 24 hours. So we were able to as was everyone, to quickly pivot and change how we did business as medical providers and as insurers. So we were able to kind of support the community that's able to care for these patients who are so fragile and really need that extra guidance and help, especially during the pandemic. So we were able to open up our networks, have a lot more access to providers so that they could do that virtual care in addition to face-to-face care. And so it really has helped expand our ability to reach out to folks if they're able to, or if they're not, we can do that consult, as I said, virtually with provider to provider. So it really does allow folks a lot of options to work through different behavioral issues, care for depression, care for anxiety, all those types of disorders that you can treat virtually. Even easier, I'm a medical physician, so it's a little harder for me to take a blood pressure, but a therapy visit is the perfect framework to be done virtually, and I think it's great. It is, as I said, it's the one silver lining we had with the pandemic that allows us to care for people in a more convenient way. And I think that moving forward, this is really going to be here to stay. This is a new way of accessing care that's more convenient for patients, and it will really help as we move forward in medical care to have that as part of our care continuum. So moving on to the next slide. And we're looking at, what is the right thing for the right group. And so there are different apps that we use. So we were able to expand our provider network, both virtually as well as in person. And it allows folks to, access a provider, through a tablet, but there are also other platforms that are very specialized. So Caden looks at substance use disorder. NoCD looks at obsessive compulsive disorder. So as we move through kind of that care continuum, we will understand where the opportunities are to provide care for those kind of subspecialty areas in behavioral health, that we can really bring access to all different types of communities. And the fact that we can do this virtually means that more people can access that care. And over time, we will really understand what works and what doesn't, because, we want to make certain that folks are getting what they pay for in terms of, employers who are paying for care, and make certain that we've made the right decisions as we move forward and look to, providing opportunities to different specialty groups to, through support with their apps, to make certain that they're able to, have that connection with patients based on what their individual needs are. So, we're very excited to be able to, provide these services, support our customers who need these services. And we also found that satisfaction with behavioral health that is done virtually has gone up. And so we know that people who are satisfied with their care will be more connected with their provider. They'll have, fewer emergency department visits. They'll complete their therapy. And it also gives them the opportunity to, before, when you used to have to kind of transfer someone over to, a different facility for a visit, there might be problems with transportation. There might be other issues in connecting. This way, you're able to actually make certain that you have that visit, and, the provider actually has you on their visit list, and so they can actually connect with that patient, if they've forgotten that visit, or say like the nurse got busy and forgot that they were scheduled for something, they'll reach out and you'll be able to complete that visit rather than having a missed appointment or having someone running behind. So really, as we look at our strategy for the future, it really has provided a lot of positives in terms of behavioral health. And then I think that also the technology will advance, because again, seniors may have a little more problem with connecting with tablets, but I think that that technology will advance over time, and that it will be a better experience both for that patient as well as for the provider. So with that, I think we're going to move on to questions. Is that correct?
Yep,
there you
that's
go.
exactly right. Yes.
Okay.
Thank you so much for that great information. And now's your opportunity to, ask our panel of experts that we have here any questions that you guys may have or thoughts. And I think the next slide, Caleb, will bring up some potential discussion.
Hello.
Hi.
Hello. Can you hear me?
Yeah, we can hear you.
Okay. My name is Leonard with Claiborne County Medical Center. We're in Port Gibson. We're a rural hospital, of course. This is one of the concerns that I may have dealing with virtual behavioral health type care is when you get into rural areas, you know that the internet is kind of scarce out there. And so you have to have a good connection either through a hotspot or hopefully that there's a cell tower close by. I don't know if you all have heard, but is there a way or have you heard about better internet connection to do telehealth in rural areas? And I have a reason for asking that. So have you all heard of any better internet connection other than your Verizon, AT&T, so forth and so on?
Yes, you want to grab that, and then I think some of our friends on the line have had some creative ways that they've worked around that.
Yep.
Yeah, and while Jessica comes up, you just one comment that, I know that a lot of visits can actually be done telephonically. And I know groups have tried to support that because you don't always have that, internet access, but doing phone calls can work if folks are able to cooperate with, using a telephone. Sorry, Jessica, go ahead.
No. You're going exactly where I was going. I think one is you have to assess where you're trying to serve the patient. Is the patient in the home setting? Is the patient in the ER? Is the patient in the LTC? I think that's the beginning point. And I know that we're about to kick off and get started working with you. So that'll be exciting to find out where the issues are in the community. And then, so that kind of leads to my next point, is to find, one of the parts of our assessment is to find where the broadband gaps are, and then come up kind of with some suggestions, recommendations of where to go from there. So Michelle Meyer said, I thought telephonically it is not reimbursable in the same manner. There is a charge code for telephonic. Am I right, Dr. Kathy, on that?
There is.
Yeah.
And in many states, keep an eye on this. Many states have just started to increase the legislation to cover this.
Mm-hmm.
So for example, with one of our other clients in Massachusetts, they just allowed phone visits for the next 2 years to be charged. So that's something to keep an eye on. Doug, you're on here. What have you guys have done some stuff around the access inequity and the technology piece. You want to let the folks know some of the things that you've been doing? Doug, I know you're there, maybe. And if not, some of the others here on the phone have done stuff too. Brad, what have you guys done? You've done some stuff around this too.
I think who else would be Nathan? I think
Nathan, yeah,
Marshall Browning.
Marshall Browning.
Came up some great concepts with iPads,
Mm-hmm.
spots.
Yeah, and it just as folks are coming off mute, I think that, obviously this is an evolution and we're still, undergoing the public health emergency. And I think things will kind of right size at some point because we want to see what works and what doesn't. But right now, I think folks are tending toward, supporting folks during the public health emergency and making sure that people can access care, because that was the most important thing, especially as we kind of were in deepest, darkest pandemic last year. But it continues and, things continue to bubble. So for the most part, that's a strategy that a lot of, companies are taking.
And same, the whole asynchronous concept with behavioral health has been a big thing that's come out as well. So it's no longer telephonic or even face-to-face, but just chatting back and forth with a provider. There's been this big push for that too, through applications.
Yeah, and some of our clients have taken things like iPads and put hotspots on them. So they've used them as the patients are getting ready for their visit, or they've taken them to the long-term care facility there and then provided a hotspot with it. So that's one option. How about Doug, Brad, Nathan? Anything you guys want to share with some of the stuff you've been doing?
Yeah, we haven't really done anything with the long-term care unit. We have used the tablets on the floor, on the acute care floor with our patients, especially those in the COVID unit. But we do have tablets available that we are using with inpatients, but we haven't done that with anything with long-term care yet. So
yeah, and Brad, how are you getting around some of the access issues, the internet access issues?
Well, that is a challenge in a rural area like where we're located. I mean, we have a lot of dead spots. So we have had to use some hot spots in some different situations and so forth. And that seems to be helpful. We've had some employees working remotely that have had access issues that we've used a hotspot, and that seems to be about our best option right now. So
yeah, here at Marshall Browning, we ended up buying 5 laptops or tablets that actually had the ability to go through and actually have their own Verizon package. So we're essentially what we're planning on doing for those, and we haven't rolled it out quite yet, was we were actually going to go through and possibly deliver those to people that were needing them at their houses, so that way they could go through and actually, if they didn't have the technology themselves, we would be able to supply it. And we already knew what was on it to begin with. So we already know it's set up and it's working fine. So as long as it just gets delivered to them, they use it, it gets cleaned off before the next visit. So that's what we've been doing here.
And then I know that in the early days, in the March, April timeframe, there were several grants that were out there for providing the internet access. And so a lot of the folks who are on the phone now applied for those grants. I think most of those have run their course, but those are things to keep an eye out for, because as we're watching with the different legislation, we know that one of the things that is still being pushed is to get internet for all. So that's another one that we're keeping our eyes on closely for the next wave to come.
Not to mention what SpaceX is doing with the satellites, and to drop the cost of internet access and accessibility without having to do all the fiber lines running. So hopefully, fingers crossed, that might actually develop to something. Mr. Ratliff, does that answer your question?
Yes, partly. I'm Mr. Paulding.
Yeah.
But anyway, partly. But one of the technologies that's about to come out that they're about to launch, that I hear has been going pretty good with testing and everything, is dealing with low orbit satellites that's supposed to have blanket coverage in these rural areas and throughout the United States. And they've been doing some test launches and everything. And I'm hearing that it is pretty good technology and it's soon to come out. So I'm wondering if that would solve the gap in reference to communication in these rural areas.
Yes, sir. Fingers crossed that program definitely will be the answer to all of our problems in the rural areas with access. I totally agree with you.
And that was the SpaceX reference that she was bringing up, Leonard. So we're on the same wavelength there, keeping an eye on it, even though, did you see what happened with their missile
I
blast? Their
know.
rocket, yeah, it went up and came down, and then after 3 minutes on the ground, exploded. So
Yeah.
let's hope they have better options with the internet.
Yeah, I think it's 968 satellites they have in orbit right now. So hopefully, I'm right with you though. I'm watching that one closely.
Okay,
That-
great. Thank you.
Yeah, that's a great question though. That's actually like number 2 on our list of one of our recommendations to think about. And it's not just at the hospital site or the clinic site, it's at the patient site. You know, it's just as much of an importance. Any other questions, thoughts, concerns? Any concerns about bridging the gap between your organization and the LTCs?
Or how about some of the information that Kathy brought up? I know the first time that I heard that information, you know, we all know that we're having issues with behavioral health within all of our communities of one form or another. But when I first saw her slides, it was very sobering for me. I mean, what do you guys think? What are you seeing with that information that she brought up? And I know that this has been an issue for all of those that we've worked with already. Because we know that telepsych and telebehavioral health have been #1 on your list.
This is Greg. Oh, I'm getting feedback. In addition to the technology issues, recruitment issues of behavioral health providers is difficult, as we all know, in rural areas. We have some, we're actively recruiting more, and we contract, which is very expensive to use a service, to the amount our budget allows. So recruitment of licensed providers, whether they be psychiatrists or LPCs or LCSWs, continues to prove to be a challenge. Thanks.
Absolutely. That is definitely an ongoing issue, and that's among, I think, all rural areas, and really beyond the rural areas. The huge shortage, I think, is the issue.
But it certainly helps with some of the points that Kathy brought up about the fact that, you know, the providers don't have to practice and actually be in the state that you're in. And Kathy, what were a couple of those other things you brought up? They don't have to be in the state, and
The time zones are, you know, it's
Yeah.
you don't have to have people that are local necessarily. And, obviously I think over time this will clarify itself, but, you don't necessarily have to credential folks in your,
Right.
in your actual facility. It's really just accessing that individual care
Mhm.
by that patient or having an e-consult. So things that I was challenged with, especially when I, worked in long-term acute care, were folks who had problems with substance use disorder and may have been in a methadone clinic. And I was really uncomfortable, prescribing those medications. So this, provides an opportunity to connect with, someone or a program to kind of help guide that therapy and allow you to care for kind of those very complex patients, who are part of our daily life. It's what we're seeing, it's what we're understanding. And so being often what I would need as a provider would just be guidance as to kind of what medication to start, how to titrate it, and then understanding when I got in trouble. And so that allows you to kind of reach out to that provider and discuss a case, or have the individual have that care plan, and then you have the kind of local primary care doctor able to do a lot more than they used to be able to do,
Mhm.
in terms of, things that are a little more challenging, substance use disorder, some of the anxiety and depression. If you've failed 1, 2, or 3 medications, which do you go to next? Those types of things where you don't necessarily need someone to lay hands on someone, but you need to phone a friend, and that's what these services really provide.
And that's great because you brought up the e-consult piece. So that's a great place where you can use it so that you can really extend the use of your primary care providers and just provide them with the e-consults. So as you know, we've met with a lot of you, and we'll meet with the rest of you that we haven't. That's one of the areas that we talk about is, can your system support an e-consult functionality? And this is a great way to use that, Kathy. So thanks for bringing that up. What else? Have your long-term care facilities been asking for this in your communities? The behavioral health and the connection back to you?
This is Brad. Our providers continue to go to the long-term care facilities at this point. So, and they have throughout the pandemic here. So I haven't really saw a need for that yet, but I definitely see a benefit from doing so. And it may be something that, if it was offered to them, they may be interested. So plan on discussing it with them. So
good. Thank you, Brad. How about some of the others? You guys are awfully quiet today. This is usually a very chatty group. You're very quiet today. Okay, well then, how about if we go to the next slide? So one of the things, and Caleb, if you could just build this all, thanks. So some of the things that we'd like you to, take away are the fact that as we started out with this, that the number of people living in long-term care facilities is on the rise. I'm sorry, all of a sudden I got all choked up. Sorry about that. And that, as you know, there's limited access to behavioral health services within the rural communities, that a lot of people within the senior population have some form of dementia, and that there's definitely some ROI for this. And a couple of things from Kathy's presentation is that, telebehavioral health and telehealth are here to stay, because as we talked about last week, the consumers are really looking for more in telehealth. So this is an important piece that we need to stay focused on. It's not going to go away. It's here to stay. And even though it may be morphing as we go into the future, we'll still have it in some shape or form. And that, Kathy, one of the things that you said that I really hooked on was the satisfaction with behavioral health increases with telebehavioral health, and that if your patient's satisfied with that, they'll stay connected. I think this is one of the things that we've heard the most from you, is that one of the big benefits of telehealth, so whether it's telebehavioral health or any of the other services, is that you've been able to connect to your patients and stay connected with them. And sometimes these are patients that you haven't been able to stay very connected to. So I think that that's a great takeaway for that. And then, just another way, as we always are with you, just think about what else you can do as you're setting up your telehealth platforms and services. Another area to go into is the long-term care facilities. So to be able to connect in there, and then also, as we heard from some of you on the phone today, to bring in other services. So it's not just kind of a one and done, bring in the telebehavioral health, but what other services can you bring in once you set that platform up, that telehealth connection to providers? What else can you help provide them with? And then, get the reimbursement there for that. So lots of interesting things that can happen with telehealth once you set it up. Telebehavioral health, as we've talked about, And then, you know, just to continue expanding it along all the different service lines. So next, I'm going to turn it over to Kim. Caleb, the next slide, please. And then Kim, back to you.
Thank you. Here's the contact info for myself and the other speakers, the speakers for today. I know that any of us would be happy to answer any questions or continue the dialogue if you guys have further information. So you might want to take a screenshot of that or kind of jot that down. We'd be glad to again continue that conversation. And with that, we'd just like to thank you all for joining us all today. We thank our speakers, of course, Jessica, Donna, and Dr. Kathy. We thank you so much for sharing such great information with us. We thank you for you guys that are joining us. We just appreciate the dialogue and the feedback from you all. And we invite you, and we can't wait till next week as we talk about post-COVID transition. And I know that'll be another great talk. It'll be the same time next week. And I will set my clock correctly. And so we'll start on time. I won't try to rush us. And we just thank you all. And we're so glad you were able to join us today. And we'll see you guys next week.
Great. Thanks, everybody.
Thank you very much.
Bye.
Thank you.
Bye.